Assalamu alaikum and welcome to this recorded lecture on cervical cancer. We are going to go through this lecture, and as you know me, I like to ask some question in the meantime and in between my lecture, just to keep you up your toes and keep you thinking with me. And I would like it if you could just try to answer those questions as they come along. Okay, let us go to the first lecture. I have to start the first slide, always with this traditional method. The objective of this lecture are to understand presentation and diagnosis of cervical cancer, discuss management options, look at cervical screening and diagnosis of cancer, understand the role of human papilloma virus, and discuss the impact cervical cancer has on women. But first of all, we want to have a look at the global impact of cervical cancer, and we can see that it is the fourth most frequent cause of cancer among women worldwide. It also causes 7.5% of cancer death worldwide, and 87% of those occur in low and middle income countries. And you can see it on this graph, which shows the red bars show mortality, and the blue bars show the incidence of cervical cancer, and you can see that these are much higher in low and middle income countries. This is a figure published by the WHO, and the darker the shade of blue, the greater is the mortality of cervical cancer in those specific countries, and we can see that in sub-Saharan Africa in particular, it is much higher than in other places of the world. So, let us come and talk about risk factors of cervical cancer. I'm sure you already thought about them. Especially, there's of course a human papilloma virus, which is connected to roughly 90% of cervical cancers. Other risk factors also play their part, but are possibly less important, and this is early sexual intercourse, many different sexual partners, smoking, reduced immunity. I have also listed the combined oral contraceptive pill here, but this is very controversial, and in fact it is thought to be related to the lifestyle associated with taking the combined oral contraceptive pill rather than the combined oral contraceptive pill itself. Human papilloma virus, as we said, is connected or seen in 90% of cervical cancers. And often you find different types in one cervical cancer or precancerous lesion, and these are usually types 16, 18, 33, or 35. Possibly we'll find other types with time. So we have talked about etiology of cervical cancer when I gave you the lecture on cervical screening. And just think back to that for a minute, and you will remember that precancerous changes precede cervical cancer by 10 to 20 years. That not all precancerous changes will stay, but the majority will actually regress. And some might develop into cervical cancer. 90% of cancers are squamous cell cancers and 10% adenocarcinomas. Those are related to the columnar epithelium of which is found inside the cervical canal, and they are not picked up by cervical screening programs. So, what is cervical intraepithelial neoplasia then? It's actually a histological diagnosis of a precursor lesion, which takes any time between 7 and 20 years to actually become cancer. Some again might regress, and if left alone, not all would become cancer. We distinguish low-grade lesions to high-grade lesions, and those are distinguished by the cell the nucleus to cell size ratio. So the larger the nucleus gets, the more high grade the CIN gets. So the larger this nucleus to cell size ratio, the more high grade the precursor lesion is. What I want to ask you, so a test has to be employed to find CIN. You can't usually see it with your naked eye on the cervix. And but where would you test for CIN? Where would you find CIN? As you probably all thought to yourself, you can find CIN in the transformation zone. As a quick reminder, the transformation zone is the part of the cervix which used to be covered by columnar epithelium, and due to exposure to acidic acids of the vagina has undergone a process of metaplasia, and during this process has become squamous cell epithelium, and within this part of the cervix, cervical cancer usually develops, and also CIN lesions are found. And this is the area, as we discussed previously, that you have to take smear tests from. So these are two pictures of transformation zones as they can appear on the cervix, taken via or looked at via a Cusco speculum. So, but how do you find CIN? That's right, you have to do a test. I've already said that. And what you have to do is actually take a biopsy from an abnormal area, and you will find a picture depicted in this drawing. From normal kind of cell packing within the epithelium due to cancerous changes, and you find that in low-grade lesions, the cell size, the nucleus, the nuclei of the cells are not yet so big, and the cells not so dense. And as it becomes more high-grade, the nuclei of the cells get bigger, and the cells are packed more densely. What does cervical screening look for then? Because in cervical screening, we do not take a biopsy, but we take a cytological sample, and we look for cervical dysplasia. Sometimes we look for a combination of cervical dysplasia and human papillomavirus, and some programs look only for human papillomavirus. What is cervical dysplasia? Cervical dysplasia is essentially a cytological diagnosis. It's also distinguishable between low-grade and high-grade dysplasia. Again, on the size of the nucleus and the shape of the cells, and this corresponds to the finding of low-grade and high-grade in cervical intraepithelial neoplasia, as it shows here. You can see on the left the normal histology and also the normal cytology, and as it moves on, changes become more high grade in both tests. So let us look now at cervical cancer. How does cervical cancer present? Yes, so it can be asymptomatic, and it can be asymptomatic for a long time. But first signs of cervical cancer are often abnormal bleeding, abnormal vaginal bleeding, and a flagship symptom is postcoital bleeding. In more advanced cancers, you would also find pelvic pain, dyspareunia, or urinary retention. What are possible differential diagnoses when women present with such symptoms? So, common differential diagnoses are pelvic inflammatory disease or the sexually transmitted infections, and these have to be excluded when women present with postcoital bleeding or with abnormal vaginal bleeding. Other invasive tumors or UTI and pyelonephritis can also be on the list of differential diagnosis. What would be your approach to a 35-year-old woman presenting to you with a 3-week history of persistent postcoital bleeding? So the first step would be taking a history. I've heard you all shout that in my face. And in this history, you have to think about getting a better idea about the presenting complaint. You have to check her personal details, as always, her age, her occupation, her marital status. Ask about associated symptoms, and if she does not mention them, you have to ask about bleeding. You have to ask about urinary problems and bowel problems, as well as weight loss. Sexual history is something that she won't usually tell you without you specifically prompting her and asking her. And you have to also complete your gynecological history by asking for last menstrual period, contraception, past medical history, past obstetric history, and drug history and allergies. What is your next step? Yes, it is an examination. This includes an abdominal examination to see if there's the size of the uterus and if there's any pain. Evaluate the abdomen for that. Furthermore, you do a speculum examination to have a look at the cervix, and really important is the pervaginal examination in this context, as often the cervix will feel very different. If there's a cervical cancer, it will have a craggly, soft feel as opposed to the firm consistency that a healthy cervix has. Furthermore, you can distinguish the mobility of the adnexa and get an idea if this tumor is kind of spread beyond the cervix in the parametrium or not. These are 2 pictures of cervical cancer. So it can look very different. It can even look a little bit innocent. Therefore, in the cervix, always the presumption is if you see something abnormal, you have to kind of look at it closer with a colposcopy and possibly take a biopsy as well to be sure it's not cancer. Other forms of imaging are also important in this context. You can use ultrasound, CT scan, or MRI. And the most useful imaging modality is probably the MRI, because it has the best contrast for soft tissue and gives the best idea about the spread and invasion, local invasion of a cervical tumor. If we look at the staging, this is always a bit dry, but it is important in cervical cancer, as a proper staging will help making the correct decision on treatment in cervical cancer. Stage 1 means that the carcinoma is strictly confined to the cervix. Stage 2 means that there's local regional spread of the carcinoma beyond the uterus, but not to the pelvic side walls and not into the lower end, the lower third of the vagina. Stage 3 shows an even wider spread of the tumor in reaching the pelvic side walls, causing hydronephrosis, or reaching the lower third of the vagina. And stage 4 is that means that the carcinoma is spread beyond the true pelvis or into the bladder mucosa or rectal mucosa. And this is a similar kind of all gynecological staging. Gynecological cancer staging follows a similar pattern. If we look into detail, stage 1A1 is actually a preclinical diagnosis that you cannot actually see the lesion. Stage 1B, you can see the lesion. Stage 1B1, it's less than 4 centimeters, and stage 1B2, it's more than 4 centimeters. Stage 2A means that the spread goes into the upper 2/3 of the vagina without parametrial invasion, and stage 2B, you find parametrial invasion but not reaching the pelvic side wall. This is a picture illustrating the extent of the cervical cancers in these early stages. Stage 3A means that the extension, an extension of the tumor into the lower third of the vagina, and stage 3B describes or means a spread of the tumor into the parametrium, reaching the pelvic side walls or causing hydronephrosis. Stage 4A means an extension of the tumor into the mucosa of bladder or rectum, and stage 4B, finally, a spread beyond the true pelvis or distant metastasis. The cervical cancers spread by lymphatic pathways and local invasion of tumor. This is a picture showing in yellow the tumor as a per stage, and this is just here to give you a little bit of help you memorizing those stages a little bit easier. Here you see ultrasound pictures of cervical tumors. Here you see CT pictures of cervical tumors. The upper picture shows a tumor that is quite large, but you can still see the stromal edge around the tumor, whereas in the lower picture you can see that the cervix and you see some spread into the parametrium of the tumor. The MRI, as I said before, is an excellent way of finding or distinguishing local invasion of cervical tumor. It helps with depicting the tumor size, the depth of invasion, and also local regional spread of the disease. Here are several MRI pictures. The pictures labeled A and B show the same tumor, which is relatively small and contained, whereas the picture below those two pictures shows a sagittal view of an advanced cancer, where you can see it's breaching into the bladder mucosa and also into the rectal mucosa, and the same tumor is seen in a cross-sectional study on the left, and again you can see the breach into the parametrial tissues. So, what is the treatment for cervical cancer? And I can hear how you all say to yourself, according to stage. And this is, of course, true. True in cervical cancer more than in any other gynecological cancer. To be sure to advise the patient the correct treatment, it is very important to have a multidisciplinary team approach in the treatment of cervical cancer. To this team, you need a gynecological oncologist, you need a radiation oncologist, you need a medical oncologist, you need a gynecological pathologist, and of course a gynecological radiologist who can help you with appropriately staging the tumor prior to making any treatment decisions. Preclinical disease, which is only visible on the microscope, or carcinoma in situ, can be treated by large loop excision of the transformation zone, and this can be done even in outpatient clinics and is often done in colposcopy clinics, this is done with this loop device. I have already showed it to you in our lecture on cervical screening, which has an electric current going through and can remove preclinical lesions very easily and effectively. It is very important that such samples are seen by an appropriately trained pathologist who can tell you if the tumor was removed completely. This has to be confirmed on a sample. Stage 1B and 2A can be treated by radical hysterectomy with bilateral pelvic lymphadenectomy. There's the choice here of external beam radiation, brachytherapy, and with brachytherapy and radical hysterectomy. Also, some more minimally invasive techniques for hysterectomy are in the development. There's laparoscopic approaches, robotic surgery, and these have similar success rates, but have a much shorter post-operative recovery period for the patient. So I want you to just think about what is taken away with the radical hysterectomy. And I want you to understand that this is a total abdominal hysterectomy, which removes the cervix with the uterus, so the complete uterus, and also a vaginal cuff. It also removes a lot of the parametrial tissues, and is therefore a difficult operation because of course the ureter goes through the parametrial tissues and has to be identified before actually removal of the uterus so that it remains intact. And this is different to an ordinary total abdominal hysterectomy, where very little of the parametrial tissue or none of the parametrial tissue is really removed, and just the uterus is removed and the cervix. Brachytherapy is all other. So this was a therapy for stage 1B and stage 2A. All other stages from stage 2B upwards are not well treated with radical hysterectomy. They need external beam radiation and brachytherapy, often combined with chemotherapy. It is very important to distinguish the stage very effectively, because if you do not, and you do a radical hysterectomy and then find that there's still local disease which you couldn't take away, the brachytherapy and radiation therapy is less effective than it would have been on the complete tumor, because it's easier to direct to the complete tumor. So brachytherapy is a very old treatment modality that was developed by Marie Curie. It uses radium as a sort of ionizing radiation to kill the tumor cells. It is applied to the tumor by this applicator, which is inserted into the cervix, and then from a distance with a machine, to kind of save the professionals working in this field, the radium is actually inserted into this applicator and can then immediately and directly be applied and work on the tumor from very nearby. This is called afterloading as a procedure. External beam radiation, which is usually combinedly used with brachytherapy, is done with these sort of machines. It is the same machines that are used for radiation therapy for breast cancer and the like. And you can see that this is a machine that rotates constantly around the patient, always delivering maximum radiation to the tumor, but by the constant radiation, giving as little dose to the kind of surrounding tissues of the tumor. So thereby saving the surrounding tissues by keeping the dose high on the tumor. Finally, and these are used in stage 2B, 3, and 4A. Can also be used and combined. Brachytherapy, external beam radiation, can be also combined with chemotherapy, usually cisplatin, for even better effectiveness. Stage 4B is a very dire diagnosis, where tumor reduction and to reduce bleeding and pain and problems from the tumor is the kind of way forward. So you might want to apply surgery, radiation therapy, and chemotherapy, all for palliation only. So what are the complications associated with these treatments. You can have acute side effects and late side effects. The acute side effects include GI tract side effects such as diarrhea, abdominal cramping, and discomfort or bleeding per rectum. And these can be reduced with giving loperamide for diarrhea or steroid enemas for proctitis. You can also get cystourethritis, which is a very disturbing dysuria, and erythema to the skin exposed to radiation. Long-term side effects are also quite profound, and they can include rectal and vaginal stenosis, small bowel obstruction, radiation enteritis, a chronic cystitis, which can be very troublesome, and also malabsorption. So what are the 5-year survival rate after this ordeal of treatment? It is, as I'm sure all of you said, according to stage, and you can see that in stage 1, actually chances are very good, whereas of course in stage 4A or 3, chances are really very poor for cervical cancer survival. Therefore, prevention is better than cure. And second, and if prevention cannot achieve, then early diagnosis is better than late diagnosis. So what ways do we have for prevention? And I hear you all say it, the HPV vaccination, which will in the future hopefully make cervical cancer a disease of the past. Secondly, you have, of course, cervical cancer screening programs, which also prevent late diagnosis and massively increased survival and decreased mortality from cervical cancer. Now, if you have any questions to this presentation, then I would like you to write them down for the moment. And then when we have our discussion sessions, you can bring them up and we can discuss your questions at that point. Thank you very much for listening, and have a nice day.